Chapter 6 Differential Diagnosis. In this chapter, I discuss differentiating avoidant personality disorder, AvPD, from panic disorder, specific phobia, and social phobia. All Axis 1 disorders, and from borderline personality disorder and Axis 2 disorder. Differentiating AvPD from panic disorder or specific phobia or social phobia. According to the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, DSM-4, patients with panic disorder have discrete anxiety attacks in places or situations from which escape might be difficult or embarrassing. According to Ballinger, these panic attacks commonly lead to avoidance of certain situations because the patient fears that if a panic attack occurred in these settings, it would be embarrassing, frightening, or both. According to the DSM-4, patients with specific phobia tend to experience fears that are excessive or unreasonable, cued by the presence or anticipation of a specific object or situation. According to a vast body of literature devoted to differentiating AvPD from social phobia, there is no real difference between the two disorders, and AvPD should be subsumed diagnostically under the rubric of social phobia. Thus, the Psychodynamic Diagnostic Manual, PDM, calls AvPD phobic avoidant personality disorder. Anthony and Swinson state that avoidant personality disorder is just a more intense form of social phobia. And Ritue, wondering if it is possible to diagnose one without the other, notes that APD may represent a more severe form of generalized social phobia with respect to levels of symptoms, fear of negative evaluation, anxiety, avoidance, and depression. While clearly both disorders overlap psychodynamically, that is, they share many of the same dynamics as feelings of inadequacy and hypersensitivity to negative evaluation, I view the two disorders both as somewhat distinct psychodynamically and as significantly different structurally. For example, many individuals who are dynamically speaking, shy, and withdrawn do not complain of being afraid of speaking in public or of anything like that. Indeed, as many actors point out, as shy people, they actively come alive when on stage, undergoing a kind of temporary antiphobia, what the PDM calls a converse manifestation, counterphobic personality disorder, only to revert to type when the play is over. Millen and Davis is also strongly suggesting that AvPD and social phobia are two separate entities, for as they note, social phobia is a symptom, Axis 1, while AvPD is a personality problem, Axis 2. Thus, as Millen and Davis say, in AvPD, there is a pervasiveness and diffuseness to the personality's socially aversive behaviors, in contrast to the social phobic specificity of the phobic object and the intensity of the phobic response. For characteristically avoidants express their anxiety in the form of what ᴈᴈ calls character armoring, that is, in pervasive and diffuse interpersonal withdrawal behaviors that run the gamut of severity, from modest problems with meeting, mingling with, moving close to, and remaining intimate and involved with other people to full shyness. Conversely, as Millen and Davies suggest, in social phobia, the phobic symptom is not associated with the broad range of traits that characterize the avoidant personality, such as low self-esteem or the desire for acceptance. As Benjamin notes, social phobics do not possess the AvD sense of being socially inept and personally unappealing or inferior to others, which lead the patient with AvD and not the social phobic to be less likely to be married and more likely to be content, even relieved to stay home by himself or herself. In short, individuals with AvPD, unlike individuals with social phobia, are not primarily bothered, or bothered at all, by reactive situational anxiety attached to discrete trivial prompts, such as signing a check in public or urinating in a public restroom. That is, they are not bothered by situations not particularly meaningful in themselves that they make significant by investing them with catastrophic implications. Rather, the life of the typical individual with AvPD is primarily consumed by diffuse, ongoing, dysfunctional relationships characterized by remoteness, shyness, and a tendency to recoil from closeness and intimacy. Patients with AvPD fear closeness, intimacy, and commitment itself, not a symbolic substitute, stand-in, or replacement for those things. In contrast, social phobics withdraw not from interpersonal relationships, but from interpersonal activities that are discrete trivial prompts that symbolize fears associated with interpersonal relationships, neatly packaged, tangible cues that act as stand-ins for interpersonal upheavals condensed and externalized to become outwardly expressed, hieroglyphic representations of inner conflict. Because social phobics keep their personality as a whole out of their phobias, they generally remain outgoing and retain the ability to form close and lasting relationships. They might well be happily married and professionally successful. Their problems tend to consist merely of troublesome eyelid, of panicky withdrawal, and insular expression of social anxiety that in turn spares the rest of their lives. Islands of seemingly impersonal difficulty in the mainstream, with a mainland full of satisfactory personal relationships. Examples of how social phobias refer to specific relational anxieties in a condensed form include a phobia of blushing, signifying being criticized for turning red hot sexually, a phobia of speaking in public, signifying being exposed as deficient and hence humiliated, a phobia of eating in public, signifying being criticized for using the mouth in situations where observed, with homosexual issues implied, a phobia of urinating in public men's room, signifying exposing one's genitals to the man standing in the next urinal, in turn implying both homosexual vulnerability and fear of emasculation, and a phobia of signing one's name to a check while others watch, signifying a fear of yielding and hence of being submissive. Some case examples. A patient expressed his generalized social anxiety indirectly and symbolically by pouring it into specific terror about urinating in public and signing his name to a check while others watched. He also condensed his fear of relating into a fear of driving to his partner's home through green lights and over bridges. He was ultimately able to reach his partner, be romantic, and have sex. Only during sex, he would suffer from pangs of fear of commitment, which he expressed as a severe ejaculatio tarda, delayed ejaculation, that made it difficult for him to complete the sex act. Dynamically speaking, he was expressing deep interpersonal fears, but structurally speaking, he was expressing them in a condensed and displaced fashion, walling off and containing the fears in short-lived, discrete, pseudo-interpersonal encounters that simultaneously referred to, obscured, and to an extent spared the real thing. This state of affairs contrasts to that which existed with an avoidant, whose interpersonal life was globally tense and unfulfilling. People afraid of public speaking can take a job where they don't have to do that, but this avoidant could not exist comfortably because he was unable to shake prophet hands, was so fearful of relating that he could not go outside without hiding to some extent, and not only developed an isolating telephonophobia, but also installed an answering machine, not to receive, but to screen messages, then neither answered the phone at all, nor returned the messages that people left for him. I believe that patients with AvPD have effectively made an unconscious choice to deal with their anxieties by developing mild to severe generalized relationship difficulties. In contrast, social phobics have made a different unconscious choice. They have chosen to remain interpersonally outgoing and related. They desire and hope to keep their whole personality out of things, and to do that, they limit their illness to part of their personality only, precisely so that they can remain generally outgoing, although with specific exceptions in the form of delimited deficits. Importantly, social phobia differs from AvPD in its effect on others. Speaking figuratively, I divide psychological disorders into hot red pepper, garlic, and onion styles. Hot red pepper disorders trouble only the self, upsetting the stomach, while others escape distress. Garlic disorders trouble others through bad breath, but the self escapes emotional dyspepsia. Onion disorders trouble both others and the self, as interpersonal bad breath accompanies personal dyspepsia. While social phobia is a hot red pepper disorder, mainly interfering with one's own functioning, AvPD is an onion disorder, for it both affects the avoidant's personal well-being and happiness and is troubling to and detrimental to others in the avoidance world. This said, Benjamin notes that especially troublesome problems of differential diagnosis arise when social phobia generalizes. This was the case for a socially phobic adolescent, afraid of going to school because of a painful startle reaction to the loud school bell. This child soon also became so fearful of all street noise that she was unable to leave the house at all without her mother. Eventually, as an adult, she stayed home with her mother all day, every day, her phobia having spread so that the only meaningful relationships she could have, besides the one with her mother, were the close relationships she developed with her cats. A careful development history can help distinguish patients with generalized social phobia from patients with AvPD. As children, people who go on to develop AvPD are more likely to pull back from others than are people who go on to develop social phobia. The latter, as children, tend to have normal relationships, both at home and outside of the home. For example, They play well with others and their peers aren't focused on picking on them. But they are more likely to suffer from childhood phobias such as agoraphobia, limiting their movement more than they limit their potential ability to relate. Therapeutically speaking, social phobics respond to treatment that emphasizes developing cognitive insight into the symptom. You fear public speaking because you feel that if you make a minor mistake, then all will be lost. Informal or formal behavior therapy that offers the patient tasks of graded difficulty geared to overcoming the specific behavioral inhibitions involved, and possible pharmacotherapy to reduce anxiety. In contrast, patients with AvPD tend to do best developing insight into the full nature and meaning of the interactive problems that keep them from becoming and remaining intimate with significant others. Conversely, it is just common sense that cognitive behavioral techniques, particularly techniques of graded exposure, will not likely be as helpful for treating an ongoing and generalized fear of closeness, intimacy, and commitment as they might be for treating an encapsulated fear of public speaking. While a patient afraid of public speaking can ask himself or herself in a reassuring manner, what is the worst that can happen, then expose and habituate himself or herself to the anxiety associated with the feared situation until himself or herself can perform comfortably and safely. Shy avoidants, afraid of intimacy and commitment, have difficulty using exposure methods therapeutically because getting over their dating anxiety would require trial intimacies and commitments, which, if at all possible, would be selfish and cruel to others in the extreme. Invoking an ad hominem argument I base on my own personal observation, I feel that behavioral therapists' vested interests in doing behavioral therapy tend to tempt them to obscure the diagnostic difference between AvPD and social phobia, so that they can treat all concerned the same way, that is, behaviorally. In contrast, psychodynamically oriented therapies' vested interests in doing insight-oriented psychodynamically oriented psychotherapy tempt them to emphasize the differences between a phobic symptom and a personality problem, such as AvPD, so that they can reserve cognitive behavioral interventions for the social phobic and use strictly psychodynamically oriented psychotherapy for the patient with AvPD. Differentiating AvPD from borderline personality disorder. The full fundamental and frequent alternate merging and emerging of borderline personality disorder has to be differentiated from types 2A and 2B, avoidant partial, infrequent, and mostly defensive shifting between closeness and distancing. As the DSM-4 says, the borderline process is notable for a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. This ambivalence about forming and maintaining interpersonal relationships leads borderlines to alternately love too well and hate too intensely, to develop close ties, then drop people impulsively, seducing, then abandoning them suddenly and without provocation or warning. We see a pattern where the borderline closes in and distances, merges and emerges, along the lines of Freud's quaint smile of porcupines, who, seeking warmth, approach each other because they are cold, but who then, pricking each other with their quills, move farther apart to relieve the discomfort, only to feel cold again and move closer together once more. One day, borderline individuals feel lonely, hunger for contact, and call and come over constantly. And the next day, they remain aloof, refusing invitations to visit or be visited, not even returning phone calls. Now, they are relentless seekers of love and affection. And now, however much they unconsciously fear loneliness and abandonment, they disrupt potentially workable relationships offered or already in progress. When they are involved in relationships, they dream of how wonderful it was to be alone and grouse vocally that relationships invade their space and feel too close for comfort. Then, when they arrange to be alone, they dream of how wonderful it was to be involved in relationships and complain that others do not get close enough quickly enough. But when they are once again involved in relationships, they provoke others to provide the match that lights the fuse, that explodes the Tümelson bomb of their long-simmering avoidant fantasy, so that they can blow up over things that people concerned with relationship maintenance would at least try to forgive and forget, not replacing ice cubes after using them, not covering the unused portion of the cat food, thus allowing the food to dry out, or putting feet up on the sofa, even when the sofa is old and the feet are clean. 2, unlike the avoidant, who distances as a way to handle fear associated with being close, the borderline merges and emerges as a way to gratify need. Borderlines first merge after overestimating others as all good, assigning individuals the qualities of savior wise and true, and actively courting them out of a need to relieve intense loneliness and achieve a sense of comfort and satiation. Only then, brought up short in disappointment, they come to underestimate others as all bad and actively dump them out of a need for vengeance, seeing only others' real, perceived, or delusionally perceived minor flaws so that they can award them the qualities of villain, fool, and cheat, in turn so that they can now avoid embracing them and instead consign them to complete oblivion. Some case examples. My team and I saw a patient without an appointment as an emergency for a 2-hour visit, then offered follow-up care the next day with both me and a psychologist. At first, the patient felt, "You people are wonderful. Look how much time you spent on me." Then, in short order, she changed her mind to say, "You people are dreadful. You are trying to overwhelm me, get too close, and press me to open up and tell you my problems before I am ready. Besides, you are only doing this for the money." This patient had, in the emerging phase, confined herself to activities that had little inherent interpersonal context. Dull, lonely things like watching television supine on the couch, or self-destructive, lonely things like excessive drinking or taking drugs. In contrast, in the merging phase, she had met and married a man after knowing him for only a few days. Then, shifting once again after another few days, claimed that she and he were incompatible and filed for divorce. A patient after breaking up a relationship with a lover over his wearing a designer belt as part of an attack skillfully geared to put the blame on him for his pseudo-sophistication instead of on her for her unrelatedness, thought twice and called the lover constantly, begged him to give her one more chance, and added, as often as she could, "I really like designer belts, and most of all, the people who wear them." Her life ultimately deteriorated into shifting from the 2-bedroom apartment with unloving roommates to the lonely studio apartment with a loving cat. Then back again, placing personal ads on the internet, but constructing them in a way that assured they were geared to get few to no responses because they were too non-committal to be consonant with the stated purpose, and frantically cruising singles bars, functions, and resorts, but drinking heavily to the point that she got too drunk to function effectively. Then, after sobering up and staying home alone for months on end, starting to think, I miss my social life, and returning to her old ways of heavy drinking and frantically seeking Mr. Right now. A patient told me of how a borderline man alternately seduced and abandoned her, keeping her involved in his charade by taking advantage of how her loving neediness rendered her too helpless emotionally to deal effectively and definitively with his alternate merging and emerging. Here is a cross-section of my conversations with Oscar. Oscar avoided me through his not matching his action to his words and lofty promises. Our conversations went something like this. Oh, I can't live without you. This life here in Paris holds nothing for me. It is a life where, sobbing, no one even caresses me. F. If you can't live without me, how come you ditched me when I went to Paris to see you? O. Because I don't mean I need you for a week or 2 weeks. I need you for all of my life and forever. F. A person that loves that much would have at least helped me when I telephoned, confused and panicked about what train to take to make my appointment with you. But you, working in your office at the train station, said you didn't know and had to hang up. Oh. Well, if that is how you feel, I respect your feelings. I never try to force anything to think differently than they do. That would be disrespectful, and everyone is a sacred creature of God. F. I don't know which part of you to believe. The one who cries because he loves and wants to be with me, or the one who is never there and seems to have no urgency at all to see me. Oh. Oscar is not a liar. He often referred to himself in the third person. He is not a liar because when he was 5 years old, his grandmother gave him a lesson he never forgot. When he tried to steal a candy when they were out shopping, she slapped his hand, humiliating him, and made him bring it back. He has never lied again since. Also, his emotions were phony. When he would cry, it would be with intense drama, but only for about 5 seconds, and then he would laugh or start a different conversation. It was more an obligatory wailing with a time limit. Also, I'm still not over the fact that he would never return my grandmother's tablecloth. My grandmother had made it by hand. She used to do cut work when she came to his country. He inherited an apartment from his mother and said it was to be for us. I had brought the tablecloth and 12 napkins over for what was to be our place together. But we never got there because he told me the workman was fixing it up and he was allergic to dust, so we shouldn't go. The next time I went to France, he told me he had rented the apartment out because I wasn't clear enough about when I would move in with him. So I asked him for the tablecloth back. He said he still had it and treasured it because he treasured everything I gave him. But he would give it back to me, but he never did, although it meant a lot to me and nothing to him. Once I got really upset and he told me he had sent it and it was on his way. But I opened the envelope he sent me. Yes, he actually sent me an envelope. There was one thing, worn cloth napkin not my grandmother's, with a hole in the middle. I asked if this was supposed to be a joke, and he started crying, saying he couldn't do anything right and please forgive him. God made him imperfectly. Also, every time we got together, after passionate email exchanges in the year in between, saying how, when we met, we were going to plan our future together, he would find a way to hatch. Here were some of his excuses about not making plans. I wasn't prepared to talk about this. You take me off guard. You jumped in too strongly and didn't wait for me to bring up the subject. My son Sasha is still under 18. I need to protect him from my wife Josette, who is crazy, and I'm afraid of what she might do to him. My brother-in-law is gay, so if I leave my son now, he may have too much of an influence on him. Your being upset with me made me too upset to talk with you about a plan. Sometimes when I was with him, I felt only hope that we would be together forever. Sometimes instead, I felt only despair that we would always be apart. Just as I couldn't live without him, I couldn't live with him. As far as he was concerned, it seems as if he could, and did, live very well either way, 1 minute with and the next minute without me.